It's second day back from laryngitis, so try to work through it. So want to talk today about rifampin, one of the three primary options for treatment of latent TB infection. Just at the outset, I have no financial ties to any commercial organization that has a stake in this talk, and I'm not talking about any off-label uses. So our learning objectives are to recognize when rifampin is either a preferred or a discouraged, missing a D there, sorry, a discouraged option for treatment of latent TB, to describe the efficacy and safety profile of rifampin, and to recognize and manage adverse effects of rifampin, all with the goal of choosing the best regimen for the patient, presenting them with their options so that they can make an informed choice, and then helping them get through therapy or stopping it if appropriate. So I always like to start out with this slide because it is our reference for efficacy. You know, it seems that all things latent TB treatment are compared to the efficacy of 9 months of isoniazid, and that, you know, we basically aim for non-inferiority. Superiority would be better, but mostly we get non-inferiority. And this is probably the best summary of the basis for that comparison, which is a re-look at the Alaska isoniazid prophylaxis program by Dr. Comstock, showing increasing gains in reduced incidence of TB among people exposed to TB and placed on INH, with diminishing returns after 6 to 9 months and the curve flattening out. So somewhere between 6 and 12 months is presumably the ideal duration in terms of risk and benefit, and we've chosen 9. You'll recall prior to the 1980s, it was 12 months. Then we went down to 6 months in the 1990s, and then back up to 9 months after 2000 guidelines came out. So briefly, looking at the three regimens, here's ours. 3 rows, one addressing each regimen, and going across the top, we get different key factors that we look at. The duration of the regimen, 4 months, 3 months for the 3-HP, 9 months for isoniazid. There's dosing information. We'll talk about rifampin in detail later. Completion rates in general are equal to the 3-HP and superior to 9 months of isoniazid. Efficacy is generally non-inferior and up around 80 to 90%. And we'll talk in greater detail about completion and adverse effects in coming slides. But again, seeing grade 3 or 4 are more serious adverse effects, much lower than isoniazid and equal to or maybe slightly lower than 3-HP. And this data largely comes from the studies that the major 3-HP trial in the early 2000s, and then Dr. Menzies' 2 studies looking at 9 months of INH versus 4 months of rifampin in adults and children, respectively. So let's look at the adults first. So this was, both of these were trials involving several thousand patients in multiple countries of varying TB incidence. This one looked at adults comparing 4 months of daily rifampin self-administered to 9 months of isoniazid self-administered, and then 28 months of follow-up after enrollment. The primary outcome was completion of therapy. Secondary outcomes measured were disease incidence and safety. So looking at completion, there was a significant difference between the 2 groups, with isoniazid having a much higher completion rate, essentially at 79 versus 63%. The number of cases in each group was not significantly different. Looking at grade 3 and 4 adverse events for 4 months of rifampin was substantially lower than 9 months of isoniazid. the majority of that difference being drug-induced liver injury. So the conclusion of that study was that 4 months of rifampin was not inferior in terms of efficacy here on this line, and it was superior in terms of completion and safety. Switching to children, similar design, smaller number of enrollees from both high and low incidence countries, again looking at the same two regimens. This time the primary interest was in, is this safe for kids? And then secondary outcomes looking at completion and disease incidence. So again, completion was superior and statistically significantly so. And similar, on the similar range to what you saw in adults, a little bit higher completion rate in both groups under these study conditions in children. And I will just say, I believe our completion rates in clinical practice with rifampin run around 80% or better. And with 9 months of isoniazid, they're more down around 50 or 60%. Okay. So this is a smaller magnitude of difference than we see in program settings, but in a randomized clinical trial, clearly an improvement. Looking at active disease, there were almost no cases. 2 cases did arise in the INH group. One was in an isoniazid resistant case, and none in the rifampin group. There were no difference in grade 1 or 2 adverse events. That's mild adverse effects that did not result in discontinuation of therapy. And there were no grade 3 or 4 or 5 adverse events in either group. So the conclusion was, in terms of completion, this 4 months of rifampin is superior, and efficacy and safety are essentially the same as 9 months of isoniazid for children. So I got my slides out of order. I actually want to come back to these drug interactions. I just want to go on for a minute about adverse effects, because that's once we choose the regimen, then we're just trying to get the patient through it. So let's keep talking about that for a minute. So going back to those studies, just again review these grades. So grade 1 adverse effect is a mild adverse effect, let's say itching, that doesn't even require any intervention. You don't interrupt therapy. Maybe you don't even provide any Benadryl or hydrocortisone. Grade 2 would be a minimal, mild effect, might lead to temporary interruption of therapy or to a pharmacologic intervention, but no permanent discontinuation of therapy. Grade 3 is a more significant effect that generally leads to hospitalization or disabling long-term adverse effect. Grade 4 is more serious with life-threatening impacts, and grade 5 is death. All right, so now if we go back to the adult study, looking at 9 months of isoniazid versus 4 months of rifampin, and look at how many times were drugs discontinued, not just focusing on grade 3 or 4, but how many times what proportion of time was drugs discontinued, we see about double the rate, 5.5% here versus 2.8% in the rifampin group. So about double in the isoniazid group. And you recall that it was 3% versus 1.2% for grade 3 and 4 adverse effects of all types. Why it's different in this table than in the results in the paper. This is supplementary data that you can get online. I'm not sure. But again, I want to focus just the large difference in discontinuation rates, about 5% versus 3%, and the big difference in serious adverse effects, 2.5% versus 1%, and drug-induced liver injury, 2% versus 0.3%. That's really what I wanted to focus our attention on. And then if we look at the constellation of adverse effects that were reported on the 4 month of rifampin's, highest, surprising to me, I've only seen a couple of rifampin liver injuries on latent TB therapy, but there were 11 total in the group. Here we go. That was the leading cause. Hematologic was second, along next to rash. These are the two that I see most in clinical practice, hypersensitivity or cytopenias. and then a mix of GI intolerance or other. Not reported here. We do see sometimes systemic adverse reactions where patients just feel like they got the flu after they take rifampin, even when it's given daily. It's rare, but we see it and have to discontinue it usually if on repeat trying it, it recurs. So now let's go back to drug interactions. When we place patients on any rifamycin, we got to remember that we're inducing the cytochrome P and the glycoprotein P efflux pumps, particularly these three isoenzymes that are involved either in the metabolism or pumping out of the cell of these drugs and other drugs and toxins. So I'm not going to review the whole list, but we have anticoagulants, we have immunosuppressants, cancer chemotherapy agents, azoles, antiviral treatments for Hep C and HIV, antipsychotics, opioids, anti-diabetic drugs, antihypertensives, cholesterol, PPIs, levothyroxine, antidepressants, anticonvulsants. Sometimes I think it's hard to find a patient going on multiple drugs that's not on one of these. It's a little more common in younger, healthier LTBI treatment patients that have them not be on these. But you just, I think the moral of the story here is you've got to be on the lookout for patients who are on these drugs or others that I didn't list that interact with rifampin, and then determine, is this a deal breaker? Can I just simply not use any rifamycin in this case? Or is it okay to use rifampin and either do clinical or serum monitoring for the effect of the drug that's interacting? Or do I not need to worry about it at all? And I'll, in general, I'll review this in the summary, but for the drugs at the top half of this, it's mostly a deal breaker. You really can't use rifampin with these drugs. Antiretrovirals, it depends on the specific antiretroviral, but it's certainly a deal breaker with protease inhibitors. With efavirenz or integrase inhibitors, you can either feel okay about efavirenz or double the dose of the integrase inhibitors. I'll mention tenofovir alafenamide, so not the TDF, the standard tenofovir that's in Truvada, but this newer one that's been developed to have less of an effect on the kidneys in the long run. That alafenamide form of the drug is metabolized by the cytochrome P system, so theoretically you can't use it in conjunction with rifampin, and patients on that need to switch. I just saw some data presented at IUATLD that suggests that that's not necessary, but I'm not going to change my practice until I see that in writing. Okay. And then these drugs generally, you can either, we try to steer away from rifampin with these two at the top and use another rifamycin. Many of these others, you can just monitor the patient clinically, or in the case of the cholesterol-lowering drugs, monitor their cholesterol if it's that important over the next 3 or 4 months. Levothyroxine, generally, you could just monitor the TSH and free T4, and same with anticonvulsants. And then the antidepressants, you'd have to monitor clinical response. But again, these aren't necessarily deal breakers, I would say, except for antipsychotics or the opioids, where use of rifamycin might seriously interrupt the therapeutic effect and rhythm that they've got going with those drugs, which is probably in the short run far more important than their LTBI. I went in the wrong direction there. That's one way of summarizing. Dosing, you can refer to this later, but there's the dosing scheme for adults. Generally, the max is 600 mg per kilo, or 600 mg a day. and we try to aim for 10 mg per kilo per day, knowing that basically our 2 doses are 450 by giving 3 150s or 2 300s for 600. So where do you step down to 450 milligrams? You certainly want to do so if they weigh 450 or 45 kilos or less. In between, I tend to go with 600. Most patients, drug safety trials suggest patients tolerate up to 20 to 30 mg per kilo per day without, those adverse effects to rifampin are not dose related. They appear to be idiosyncratic. So I don't get too worried about fine tuning the rifampin dose, and most adults can just take 600 unless they're very small. Children, remember that the dosing has been updated from 10 mg per kilo per day to 15 to 20. And it's even, I think, 20 to 30 if they have TB meningitis. So remember to dose kids more up toward 20 mg per kilo per day. And then try to do that, giving 120 doses within the target duration, maximum duration of 180 days. So 4 months within 6 months. And it's easy to do with adults. With kids, it's a little harder to fine tune the doses, but remember that they have a fairly wide therapeutic range, and try to aim toward 20 and see if you can do it with capsules. I'm not a big fan of putting either isoniazid or rifampin in syrup. It can cause diarrhea. It reduces the stability of the drug, so theoretically you have to dispense it more often. Some pharmacists say as often as every week. I've had other pharmacists say it's fine for a month. So I don't know where to land. My approach is to avoid using syrup and just try to dissolve capsules. Okay. In semi-solid food is generally what we're trying for. Safety monitoring, very similar to isoniazid, but with a greater degree of safety, knowing that we induce liver injury only about 1/3 or 1/4 as often as we do with isoniazid. So baseline and monthly patient education, as Dave emphasized in his last talk, that's the first primary guard against liver injury or serious liver injury, is making sure the patient reports changes in appetite, nausea, vomiting, or worse, jaundice. Monitoring patients clinically prior to releasing their next refill for adverse effects of liver injury, hypersensitivity, gastritis. If they're fatigued, that could be liver injury. It could be hematologic. So don't forget, if you're checking a patient who's feeling fatigued or not well, to also check their CBC. And then LFTs generally are reserved at baseline and monthly for patients who have known risk factors for underlying liver disease or drug interactions that would increase their risk of liver injury. So HIV, chronic viral hepatitis, other hepatobiliary disease, regular alcohol users, other hepatotoxic meds, and pregnancy in the immediate postpartum period. Hematologic monitoring, I tend to defer. I don't really see anything about it in the guidelines, so I tend to defer it on doing it at all unless the patient has an underlying anemia or cytopenia coming into therapy. And if I don't know about one, generally, frankly, I don't check unless there's reason to believe they have one. And we discussed earlier, I think I covered clinical or laboratory monitoring for drug interactions. With respect to adverse effects, in general, if there's a serious adverse effect, stop the drug and generally don't restart it. It's latent TB. Either pursue another regimen later or give up for an adverse effect of that degree of seriousness that you think is reasonably attributable to the rifampin. If there's a mild to moderate adverse reaction, continuation of therapy is reasonable, and you can either treat it or observe without pharmacologic treatment aimed at that adverse effect. I'm a frequent user of topical hydrocortisone, diphenhydramine, ondansetron, PPIs as necessary to control those kind of mild adverse effects. And then I want to encourage you to report any LTBI treatment-associated hospitalizations or deaths to this reporting email line. So in summary, 4 months of rifampin is generally non-inferior in efficacy to 9 months of isoniazid, superior in terms of completion and efficacy and safety. It's roughly similar to 3HP based kind of on comparing data across studies in the big picture. There's very limited head-to-head data comparing these two regimens. Adverse effect related termination appears to be about 3% for rifampin. Severe drug reactions about 1% or less. Liver injury occurs much less often than with 9 months of isoniazid and a bit less often than 3HP, which is intermediate between the two. I find it to be the preferred regimen for contacts to isoniazid-resistant TB. Other patients for whom I actually, it's my go-to regimen, and then I go to the others from there. So, but definitely you want to use it in INH resistance when there's a contact who's infected and the source is known to be rifampin sensitive. Drug interactions, generally rifampin is going to be incompatible with anticoagulation, immunosuppressants, HIV, Hep C, and cancer therapies. You want to monitor and respond to other drug interactions as appropriate based on clinical or laboratory monitoring. In select situations, you may elect to use rifabutin instead of rifampin when drug interactions arise. This has not been studied for LTBI, but it has been endorsed in the HIV opportunistic infection guidelines. I think it's a reasonable exercise of clinical judgment, just knowing that you're kind of getting a little bit off the standard TB treatment guidelines, and consider consultation with a LTBI expert like Dave or Masa if you get into that situation. That's it.
Great. That was fantastic, Chris. Thank you so much.
Okay. Any thoughts, questions from here or the group?